And now we'll have Dr. Arsanjani come and speak to us about multimodality imaging.
Thank you. Perfect. There's still no disclosures. So I always like to start with this. I actually got this from one of my colleagues. What Einstein said, that computers are incredibly fast, accurate, and stupid. Human beings are incredibly slow, inaccurate, and brilliant. Together, they're powerful beyond imagination. So when we're talking about AI, it's never to replace us, right? We're going to be the idea is that I remember the first talk I gave in 2013 in Korea about AI. People said, oh, I had a bunch of radiologists line up and they were worried that they're going to lose their jobs. And I said, no, no, no. We're still going to be at the helm. We're going to make the final decision. This is a tool that's supposed to help us. And it's been around for a long time. If you actually look at the neural network concept, the first paper published was 1943. And if you look at the Turing and McCarty, which are kind of, we think, are the founders of, or fathers of AI, they were around for a long time ago before we started actually looking at it. But the first FDA approved for the first medical device in patient care without physician oversight was in 2018. And often we talk about machine learning, and again, not that it's not an AI talk, but we talk about supervised learning. This is where we actually have to label it. So we have a bunch of apples. I tell the computers that this is the apples. Then I feed a bunch of information. Then it identifies, is this an apple or not? Unsupervised is that we actually feed all the information to the machine. It looks at it and says, I see some apples, I see some oranges, I see some bananas. So it actually looks at and clusters individuals, and that potentially in an unsupervised is much easier, doesn't take as much oversight, and identifies different groups that might be different, and you look at it and see, okay, are the differences between them? And it's here. We see it all the time, right? It's all the devices around us. It's currently being used in the airports for security purposes, for traffic, we use AI all the time, but we don't really think about it. And I always say, why does it matter? Why do we care about AI, right? And the idea with it is that in 1950s, medical knowledge, they should take 50 years for medical knowledge to double every 50 years. In 2020, it's every 73 days. So the idea with it, the medical knowledge is significantly and rapidly accelerating where we're not able to keep up with it. And if you look at it, if a medical student who graduated in 2020 would only have 6% of the information the 4 years that they were there that they actually could have learned. So the idea with it is that we're going to need help when we actually see patients. And we all know, and everybody who sits here, our patients are getting older, they have multiple comorbidities, they're sicker, there's an obesity epidemic, and you're looking at it if you look at the data, 53% of individuals from Milken Institute have incidence of diabetes, 62% cancer, heart disease, hypertension. All of these are expected to increase as we move on. So what's the role of what's the role of AI in echocardiography? So again, a lot of it, we can think about chamber recognition. We utilize this for our models. I'm going to show this. We'll think about quantification, right? If I'm reading a report, it can calculate your ejection fraction, can give you your E velocity, it can tell you your peak tricuspid regurgitation velocity. It can actually assess different chambers, and it can look at cardiac disease detection. And that's been our major focus, because I don't really care if the walls are 15 millimeters. I don't care if the walls are 20 millimeters. What I want to know is that 15 millimeter wall, does that patient have hypertrophic cardiomyopathy? Does that patient have AL amyloidosis? Does that patient have a disease that I can intervene on? So the actual wall thickness doesn't really matter. It does. We will look at it because that's what we've done historically. But I'd much rather the model help me say, this is a particular disease that you have to be worried about. So when we're thinking about it, can utilize image acquisition. There's multiple different companies that have looked at it, kind of what we call GPS-guided image acquisition, where you have somebody who's novice. They can give this people who have never scanned, and basically the device looks at it and says, okay, move your wrist to the left, move up a little bit, and it can help with the image acquisition for somebody who's a novice. Or you could look at analysis and look at the disease detection. And it's always important when we look at this to kind of take it back to the real world. And I think that I have 3 cases of where we started with this idea of utilizing AI in our echo analysis. So it's a 55-year-old gentleman, has a history of heart failure, diagnosed approximately a year ago, unknown etiology, was hospitalized at another facility in town for 4 weeks, had an extensive workup, had coronary angiography, had a process 1 AFib, subsequently underwent AV node ablation, had resynchronization therapy, had TE, cardioversion, thoracentesis, paracentesis, had 2 echocardiograms at the outside facility, both commenting on the fact that his walls were thick. He got discharged. Wife basically brings him back the same night to our ER. I'm on call that night. I got a call from our fellow. It says that this gentleman is in the ER where he's in cardiogenic shock. His blood pressure is 80/65. We go. This are some of the markers. Hemoglobin was 15.4. Creatinine was 1.1. Troponin was elevated. NT-proBNP was elevated. And you can see again his voltage on his ECG was low, but he was being paced. If you look at these images, again, majority of us, and I have an 8-year-old at home, he can look at that echo and say, that's not a normal echo, right? So we can say, at this stage, this individual, the walls are thick, there's a pericardial effusion, the right ventricle is thick, both chambers, the function is down, kind of has a restrictive filling pattern, apical sparing pattern on longitudinal strain, kind of the cherry on top. So all of it kind of fits. Okay, this guy has amyloidosis. We diagnosed it. So we send light chains. The guy has AL, and the myocardial biopsy and bone marrow confirm it. He started getting started on therapy. Unfortunately, we caught him too late, succumbed to the disease, right? So he sat around for a year. He had studies that said the walls are thick, but the dots were not connected, unfortunately. And we hear this all the time, right? We have patients, we say on average, a patient sees 5 cardiologists before the diagnosis gets made, and cardiologists only make approximately 19% of the diagnosis for amyloid. So we miss a lot. So shows again, amyloidosis with diagnosis was missed. And the idea is that could we have came up with an AI algorithm to look at this? And that's where our first kind of paper that we looked at this. Oh, sorry, can we go back one image? One more. Okay. Sorry about that. Okay. So we basically took 6 images. We took a peristernal long axis, which is on the right here, peristernal short axis at the level of the mitral valve, mid ventricle, and then apical 4, 3, and 2 chamber. We combined it with AI, and we said, okay, let's run the algorithm. It runs in the background, gives a probability score based on frames, and we ended up differentiating. And we were interested not so much in differentiating amyloid versus normal. And the example then that I use all the time, again, my 8-year-old, if I show a normal echo and I show an amyloid, he can look at those, say, okay, this one's different, right? But the idea is that I want him to see if you have somebody with increased wall thickness, and we see that about 40% of the cases, can you pick up, is that hypertrophic cardiomyopathy? Is that hypertensive heart disease? Or is that amyloidosis? And the model was able to differentiate between that well, and you can see that the ROCs for that was about 0.91, 0.95, 0.95. And this is what we call the heat map. And what the heat map does, it actually allows us to see what the model is looking at. And the area that it was focusing on was the ventricle. So on the next set of images, it's always important for us to kind of show what the model is looking at. So we started doing ablation studies. And the ablation study means we started getting rid of a chamber. So when we got rid of the left ventricle, the model's performance went down a lot. We got rid of the left atrium, the model performance dropped. Again, right ventricle, right atrium was the one that was best tolerated. So when we're looking at it, when we do an ablation study, it's important. And the reason we do this is because we want to make sure that the model is actually focusing on the heart. I was actually talking about a case earlier. So there was a model that we were looking at initially, looking at restriction versus constriction, 2 different diseases that can manifest in a similar fashion. And when we ran the model, immediately the performance was 0.99. And we know right off the bat there's something wrong. When the performance is that good, right off the bat, you start having to question the model. And when we saw what it was looking at was a respirometer, which is a line that we have on the echoes with people with constriction, and the people that were having restriction didn't have that line. So the model wasn't even focusing on the heart. It was just looking at that line and saying, okay, if you have that line, you have constriction. Obviously not helpful because we want to make sure that this model is looking at the right thing. So we had to introduce fake models, get rid of the lines, fake lines in, and then the model started performing. So you always have to do ablation studies to see if the model is actually looking at what we think it's looking at. I'm going to show a second case. Again, so this is a 69-year-old female, history of dyslipidemia, had ulcerative colitis, had a ileostomy, had a provoked DVT at the time, and he presented to for 3 weeks history of fatigue and nausea. In the ER, blood pressure is 130/80, heart rate is 120 to 130. She's in AFib, normal hemoglobin, normal creatinine, normal renal function, troponin is 24, and NT-proBNP was a little up, but it's been going on for 3 weeks. Simple, patient comes in, we see this day in and day out. We're going to do a TE cardioversion, get her, we started on blood thinners. This is our echocardiogram. I don't know, it's not the best image quality, but I would say overall, if you're looking at it, there's some beat to beat variability. The walls don't look quite that thick. The left atrium is not enlarged. Overall, not very exciting. And we do the TEE, and sure enough, she actually has the left atrial appendage thrombus, which is a little bit unusual. She's only been on it. Her CHAS vascular was 2. Overall, we were not expecting that we were going to see this. So I said, well, let's run. Could she have something else? So just kind of fly through this again. Do we start her on the blood thinner, repeat the TE in 4 weeks, and do a cardioversion? Do we just, start at apixaban and then don't do a repeat TE and do a cardioversion? Do we consult hematology? Do we go rate control? Do we consult EP? And what does she have? Does she have hypertensive heart disease, amyloid, HCM? Again, we're in an amyloid meeting, so she's going to have amyloid, but sorry, I'm going to. At Mayo, we actually have in our EPIC system, we actually have this algorithm with everybody who gets an ECG, we get a printout of whether they actually have hypertrophic cardiomyopathy, do they have amyloid, do they have cirrhosis. We can actually look at age and gender, and you can see that the ECG felt very confident that this individual has amyloidosis. And this is data from Martha Grogan and team in Rochester, and they showed that they were able to identify, again, with the ROC of 0.91, identify individuals with amyloidosis. So we did an MRI, and sure enough, she actually has diffuse late gadolinium enhancement involved in the left ventricle. We had, you can see that, again, this is supposed to be black, and you can see it's quite white. This confirmed diagnosis. Biopsy, again, she has AL. And again, this is after chemo. Now you can see that the atria are now beginning to get larger. That apical sparing pattern that we saw that, we didn't necessarily appreciate the first time around. So she actually has AL. So this would have potentially been missed, right? But would have just saw her, had she not had the appendage thrombus, would have not raised the flag, we potentially could have missed this. So the take-home message is that the first case, the patient had echoes. Walls were thick, diagnosis wasn't made. The second one, we would have looked at ECG and said, yeah, the voltage is a little low. I don't know. We see a lot. You read 400 ECGs in a day. Everything looks like a squiggly line. So you would have not been super excited about it. But the idea was that could we actually combine both the ECG and echo to kind of get a better model? And the reason it's important for us, and this is a discussion we always have, when we look at AI, we never go and see a patient and make a diagnosis just based on labs or clinical history, or just echo, or just the chest x-ray, or just the ECG. You combine those data and you come up with a better guess based on pattern recognition. That's what we do as humans. So why can't the model do that, right? We don't want to just depend on one entity. You want to gather as much information as possible and come up with an answer. So when we did this, we actually took the echo. The echo gives us an output, and we just took an apical 4-chamber, and we did this with a 2-lead ECG just because of the fact that we just wanted to see how many leads we needed to simplify this. And remember, our initial model has 6 images. Now we're only going to focus on the apical 4-chamber, and our ECG was 12-lead, and now we want to do a 2-lead because, again, with the Cardia, although now Cardia has both 6 and 12-lead now. But the idea was that do we need that entire information? So when we did this, when we combined it, you can see that we actually had a decent performance for ECG alone. So if we have ECG, we can give you an answer differentiating. If we had an echo, we can give you an answer. If we have both, we give you a better answer. So more information, the better our model is going to perform. And then this popped up. So this was an interesting case. So the way this works is that what we call confusion matrices. So on the on the y-axis is our true label. So all of these patients at MRI. So we said based on MRI, this individual was identified as either not having hypertrophic cardiomyopathy or amyloidosis. So we thought that this patient had hypertensive heart disease. The model, on the other hand, said, I think you guys are wrong. This patient has amyloid. I said, no, we looked at the MRI. We're pretty confident. So I told our data scientists who actually are upstairs here, I said, can you guys send me this case? I want to really kind of delve into this because the model is very confident this patient has amyloid. So we started looking at this patient. This is a 52-year-old guy that had presented, has history of diabetes, hyperlipidemia, did have a history of neuropathy, came in with syncope. In the ER was noted to be hypotensive, and he was subsequently discharged as having vasovagal syncope. Run of the mill, we're in Arizona, it's hot and dry, people pass out all the time, been guilty of it, so not very exciting. So, labs, again, troponin is negative, BNP was marginally elevated, ECG, lower voltage, but you could see that in a bigger guy, so I said, okay. Echo, strain doesn't look typical, right? Pretty good. MRI, no late gadolinium enhancement, right? Minimal at the insertion points we see, but it's non-specific. Not really quite, sorry, it kind of came up pretty black. So what does the guy have? Well, we're in an amyloid meeting, right? So he has systemic amyloidosis. So interestingly, he has it, right? So we would have looked at the criteria and would have said, well, this guy doesn't have cardiac involvement. But the model clearly sees an abnormality that feels confident that this person has it. And on the previous talk that I just had, we talked about the PYP. And again, what's the false negative rate on the PYP when compared to the endomyocardial biopsy? We said that's about 5% based on the French data. But a lot of times what we wait, and often we see people, is that we present, the way we identify amyloid is when they present late. We identify end-stage disease, right? They have significant cardiac involvement, the walls are very thick, they're already having significant symptoms. But that's like waiting for somebody to have metastatic disease before we say, oh, we should start therapy, right? Ideally, we want to catch these people earlier. So could we do that? Oh, sorry. One more back. So what we did with the model, we subsequently added normal cases, and the performance even gets better. Because once you have normals, because if you only have 3 cases, amyloid, hypertrophic cardiomyopathy, and hypertensive, the model says if it's not amyloid or it's not HCM, it must be hypertensive. But if you have normal, then the model can differentiate and put another bucket. So the performance of the model, you can see the AUC for the model is quite robust. So we created this, and this is multiple different algorithms that we have, and one of them is, again, this kind of thick wall cardiomyopathy. So when we click on it, this is what we have. So you actually go, you can drop a ECG. This can be as any image, JPEG, PDF, whatever you want. Then you basically just upload a 4-chamber view. The model runs, and it gives you this fusion, and it kind of differentiates, okay, is this normal hypertrophic cardiomyopathy, and then it gives you this heat map. So we run this. You can actually run this and have just these 2 data points uploaded, and you can actually get this kind of fusion model and kind of spits out, in this particular case, feeling pretty confident this individual has amyloid. So a couple of different cases. Again, I talked about this is a 71-year-old gentleman, had bypass surgery 5 years ago, came in with some dyspnea and exertion, ECG, some nonspecific changes. This is, again, that model that we have, just the ECG alone, doesn't pick it up. That X kind of tells you, again, the dotted line is where we think amyloid or HCM. Is not impressed. We ran our model on it, and the model actually comes back as, again, the ECG thinks, I'm not impressed, and I agree. I mean, again, it's kind of some changes. The interesting, the echo thought, maybe this could be HCM, but the combined model actually comes back as amyloid. So it actually takes data from each. It's not that ECG is 50%, echo is 50%, the end result's 50%. It actually combines the data points to come up with it. And this individual had a fusion model of amyloid. Sure enough, looking at the PYP, it was positive. So again, kind of prediction. This is a very interesting case. This is actually a patient of mine. He's a retired physician, brilliant guy, came to see me in 2020, had some dyspnea and exertion. Older gentleman, troponin was mildly elevated. Sorry, go back. Thank you. Mildly elevated. At the time when we looked at it, his ECG wasn't really impressed. We said, okay, this is his echo. Strain was within kind of quote unquote normal range, beginning to look like maybe apical sparing pattern. We said, well, you know, his troponin's elevated. He's an older gentleman. Maybe he does have something. So we ran it. His PYP was negative in 2020. But he's a pretty, as I said, pretty smart guy. And he comes back and sees me the next year. He says, you know what, I'm really concerned. I ran the PYP again in 2021, still negative. At that point, I offered him, I said, you want to have an endomyocardial biopsy? He says, I'm not bad enough, let's hold off. And I've been seeing him ever since. Then in 2025, his PYP is positive. So 5 years from the time that we were concerned about to the point that he became positive, right? So we said, let's go back and look at his stuff from 2020. We ran the model. So we're going to now go back and look at the ECG and echo that was available 5 years ago. And when we run the model, again, upload it. Sorry, it's going to, you guys probably get bored of this. And we uploaded the ECG and echo. And you can see that the prediction, patient has amyloid. So we would have potentially picked this up 5 years ahead of time. Again, highlighting the fact that the imaging testing that we use is for later in the disease, meaning that potential, because again, we talked about it, often patients are quite symptomatic for a number of years before we can actually diagnose them. And we can't go biopsy everybody as much as I advocate for it, but my heart failure colleagues think I'm crazy, so they usually hang up on me. So the idea with it is that they went back and looked at 2021, again, strain, would have been not really exciting. Now you can see that the probability of amyloid had actually increased. So disease a year later had increased. And then in 2025, when we actually started him on therapy, right, now he's getting more of that apical sparing pattern. Interestingly, the disease prediction decreased. So the model obviously picked up something. So 2020 was amyloid. Probability of it even increased in 2021. On 2025, after therapy, the probability decreased. So it's picking up something that maybe the disease actually is responding to therapy. 6 months. Yeah. And now we have this available, so we can actually now, because again, I'm being lazy, I don't want to just type, like, put a PDF and an ECG. So now we just type in a medical record number, and the model actually gets pulled from the background. And we run this, and we have started this as of beginning of December, runs on every echocardiogram that we get done regardless. And the reason we want to do that, and again, have it highlighted, is because if we're not looking for it, right, if the data, if we're not thinking about it, we want the model to say, basically punch you in the face and say, this is a problem. You gotta do something about it. So we want to have an information, even if you don't think about it, that the model dings and says, there's a concern. And we actually have a model that can actually, we did this looking at the subtyping based on echocardiogram. And the model actually does fairly well differentiating between AL versus TTR as well. So again, like self-driving cars, medical AI is here. We're going to have to deal with it. But the goal is that we want to have human intuition to remain at the helm of the decision making. We want to gather all of this information and us to be the person that actually makes the final decision in regards to management. And again, possibility only limited by imagination. Thank you.
Well, thank you both for